In this PowerPoint, I am going to spend a little less time on discussing anatomy and spend more time on physiology because you will get a lot of the anatomy within lab. So I'm just going to briefly go through some of the most pertinent parts so that way you can kind of understand whenever I use those words in the physiological portion of this PowerPoint exactly what I'm talking about. For the female reproductive system, of course, just like the male reproductive system, this is going to produce sex hormones and functional gametes. It will also protect and support the developing embryo, which we do not see in the male reproductive system. And of course, we do not see in the male reproductive system any nourishing of the newborn infant. So there is a lot more complexity that is going to be involved in the female reproductive system than what we saw in the males. The main organs for this system are going to be the ovaries, the uterine tubes, aka fallopian tubes, the uterus, the vagina, and then the external genitalia. Looking at this mid-sagittal section, what you can see here is if we look, let's start at the external genitalia. So let's start from the outside, let's go superficially, and then work our way deep. On the very outside, what you're seeing that's actually not even labeled is the Labia Majora, where the pubic hair will be. Move up superiorly, you'll see the Labia Minora. Move up superiorly, you'll see the clitoris. Continue to move on up superiorly, you'll see the accessory glands, including the urethral glands and the greater vestibular glands. And then what you want to really focus on is you see the bladder with the urethra. Okay, the bladder with the urethra is obviously going to be a part of the urinary system. In the male reproductive system, we talked about how that urethra is shared for both sperm travel and urine travel, but that is not going to be shared within the female. So now put your eyes on the uterus, which is superior to the bladder. The uterus is going to be the place where the baby will live for 40 weeks. And then if you move down from the uterus, then you will see a canal there that is the vagina. So whenever you're looking at the uterus, you can see how it's on top of the bladder, which now hopefully makes sense to you as to why women who are later in their pregnancy, maybe in trimester 3, always have to pee, because as that uterus expands and the baby grows, it actually puts more pressure on the bladder and doesn't allow it to fill as much, so she always needs to go to the bathroom. And then moving up completely above the uterus, what you can see there labeled is the ovarian follicle, so that would be inside of the ovary. And then that little tube that you see wrapped around the ovary is going to actually be the uterine tube. We'll be talking about multiple structures here that you see on this mid-sagittal section as we go through and talk about what's going to be happening inside of the female reproductive system and how homeostasis is going to be maintained here. So on this picture, what you can see, again, we are highlighting the ovary and the uterine tube, also known as the fallopian tube. Now you can see the uterus is labeled and you see 3 other words: perimetrium, myometrium, and endometrium. Remember, anytime you see the word endo, that means indoors. So endometrium is going to be your innermost layer of the uterus. The myometrium, myo means muscle, that is the muscular layer, the very thick layer of the uterus. And then perimetrium, of course, it surrounds the perimeter, so that's going to be on the outside of the uterus. It's very important to know the difference in the 3 layers of the uterus, because when we talk about the physiology of what's going to be happening inside of the uterus, you'll want to be able to keep those things straight in regards to what's happening with those layers and what hormones impact those layers. Then at the very tip of the uterus, what you see is the cervix. So the uterus is almost kind of shaped like an upside down pear, and that cervix at the end is the piece of the uterus that will protrude into the vagina. This is the piece that actually will be tested when a woman goes to her gynecologist for her pap smear. So whenever she's laying on the table and they insert the tools into the vaginal canal, they're actually trying to swab the cervix and check for things that are called cervical dysplasia. So cervical dysplasia basically means abnormal cells on the cervix. They'll put those underneath a microscope, see what's going on, and then kind of go from there in regards to if her pap smear comes back abnormal. Hopefully everything comes back normal and everything's fine, but if not, then you kind of have a greater understanding of what needs to be done based upon that pap smear. Moving on down, you have the vagina. So the vaginal canal, you can kind of see there. Whenever we are looking at the vagina, remember this is going to be the area that is going to receive the penis during sexual intercourse. So as the sperm is traveling out of the male, out of his external urethral orifice and into her vaginal canal, the sperm has to travel up that acidic vagina, get into the cervix, and then ultimately find its way into the uterine tube. So this mid-sagittal section isn't really the best way to see that, but we'll be looking at a couple of other different views so that way you can see exactly how long that journey is going to be for that sperm. And then lastly, the external genitalia, we already kind of talked about that on the last slide. Labia minora and labia majora are going to be things that you can see from the outside, and you do not need any tools or equipment to go in and view these external structures. So the ovaries are small almond-shaped organs near the lateral walls of the pelvic cavity. Although they are small, they are certainly mighty. Whenever I was in my doctorate program, we did human dissection. We did not use animals. We used actual humans. And I will say by far the ovaries were the absolute coolest things to see. We had a very old woman as one of our specimens. We also had a middle-aged man, but in looking at that woman's pelvic cavity, once we found the ovaries, it was so incredibly small, and I just looked at it and remember thinking, gosh, all of the work that this structure does, despite how small it is absolutely mind-blowing. So these ovaries have three main functions. They are going to produce the female gametes, which are called oocytes, and that is going to be done through a process called oogenesis that we will discuss. They're going to secrete the female sex hormones, estrogen and progesterone, and I will show you how. And they're also going to secrete inhibin. So just as the males secrete inhibin, females are also going to be secreting inhibin, and again, it's going to be involved in that negative feedback control of the FSH release from the anterior pituitary, just like it is in the males. So when we're looking at the uterus from a frontal view, what you can see here is that upside down pear. So the top of the uterus is going to be referred to as the fundus. So the superior most section of the uterus is the fundus. The main portion of the uterus is the body, and then that very inferior tip is again the cervix. So the uterus has three portions, but it also has three layers. So as that sperm is swimming up the vagina, it will go into the cervix, travel superiorly up the body of the uterus, heading towards the fundus to ultimately swim into that uterine tube or fallopian tube, and then it will travel through the tube. So you can see that the tube has different names according to which part of the tube we are in. The first part that's closest to the uterus is called the isthmus, and then you have the ampulla, and then curve around into the infundibulum, and then the last portion is the fimbria. And the fimbria is the portion of the tube that is closest to the ovary. Please go ahead and write a little note right here that the fimbria of the tube is not directly connected or attached to the ovary. Even though it looks like it in the picture, it absolutely is not, and it's vitally important to understand why pathological processes can occur in females the way that they do, because of this disconnect between the fimbria of the uterine tube and the actual ovary itself. So there is no direct connection there, but that fimbria has those finger-like extensions that I'll be talking about a little bit later on. Remember, structure and function always go hand in hand. So I'll explain why that fimbria has those specific finger-like extensions instead of just looking like the rest of the tube. When we're looking at the inside of the tube, this is going to be ciliated columnar epithelial cells. Again, structure and function, we have cilia inside of the tube because that is going to help propel the oocyte in the correct direction to hopefully help it meet up with the sperm if the goal is procreation. There's also scattered mucin secreting cells that will be within this tube to kind of keep everything nice and moist. There is mucosa that is surrounded by layers of smooth muscle because smooth muscle will allow for peristaltic contractions, which will also help with moving that oocyte as well. For fertilization to occur, the secondary oocyte, we haven't talked about that yet, but the secondary oocyte has to meet the sperm within the first 12 to 24 hours that it is within the uterine tube. So there is a very short time frame that will be the time frame that is going to allow fertilization to occur. It will typically occur near the boundary between the ampulla and the isthmus. It's important to remember that because when it comes to fertilization, implantation, procreation, all of this is incredibly systematic, and there are things that have to occur in order to make this process be good from beginning to end. So truly every kid, I know people say, oh, children are a miracle, and really they are. But every time a pregnancy happens, it is a miraculous process because there are so many things that have to occur at just the right time in order for that pregnancy to actually come to be. So, incredibly important. Remember, we're going to talk about it in a little bit. Between the ampulla and the isthmus is where fertilization should happen in order for everything to work appropriately. Peg cells within the epithelium will secrete the fluid that completes the capacitation of the sperm. In the male PowerPoint, we talked about how capacitation was necessary in order for fertilization to occur. So the capacitation has to happen in order for the acrosomal reaction to occur so that the sperm can penetrate that oocyte. The peg cells will also supply nutrients to the sperm and the pre-embryo. Nerves of the uterus include the autonomic fibers from the hypogastric plexus as well as sacral segments S3 and S4 when we're talking about sympathetic and parasympathetic. Segmental blocks such as epidurals that are going to be used during L&D are going to target the spinal nerves from T10 to L1 so that the woman does not feel what's going on. We may talk about epidurals a little bit later on, but we're not going to get into that too much at this point in time. If you are going to do an epidural, I highly encourage you to do some research and make sure that that is for certain absolutely what you want to do. Don't just do it because that's what everybody else does. The uterine wall, again with the 3 layers, is a perimetrium, myometrium, and endometrium. For the endometrium, you want to write a little note to yourself right here, star this. This is that layer that will be shed during the menstrual cycle. So this is the layer that we're going to be talking about when it comes to menses. So important to remember that this is what is actually coming out as the period blood. Okay, it comes from the uterus, and so the endometrium being shed is related to hormones, timing, etc., etc. We'll go into all of that. The myometrium is the thick muscular layer that is going to be responsible for uterine contractions. So if a woman is having a baby, it's that myometrium that's going to help push that baby out of the uterus. If she's not having a baby, if she's having cramps, it's that myometrium that is causing her that pain. So we'll talk about both of those a little bit later on. Okay, here we go. Myometrium, 90% of the mass of the uterus. So you have smooth muscle that's arranged into both all three, longitudinal, circular, and oblique layers. And as I said, provides the force to move from the uterus into the vagina for that baby. Endometrium is only about 10% glandular and vascular tissue that is going to help support the physiological demands of a growing fetus if she is pregnant. If she is pregnant, she's not going to lose the endometrium, which is why you're not really supposed to have a cycle whenever you are pregnant. Now, sometimes it does happen as a fluke. There are situations where a woman can have a little bit of a cycle before she even realizes that she's pregnant, but normally when the cycles stop, if she is sexually active, that's the clue. Okay, you're not going to lose that endometrial layer because it is supporting a growing baby. We have many uterine glands that will be within the uterus to help kind of support that endometrial layer, and then estrogens cause those glands, the blood vessels, and the epithelium to change monthly. So we'll be talking about estrogens, where it comes from, and how it's going to make changes within that endometrial layer. There are two divisions of the endometrium, so make sure you star this. The functional layer is the one that will be shed each month if she is not pregnant. The functional layer is the one that contains majority of those glands, and it will be the one that contributes to the endometrial thickness. So the functional layer is going to go through dramatic changes as the woman goes through her uterine cycle each month. If she's not pregnant, it'll shed and it becomes very thin. As she goes through her cycle days, it grows and builds in order to maybe support a baby. We'll be talking about how all of that works, but just keep in mind that as we talk about changes within the uterus, we're talking about the changes within the functional layer of the endometrium. If that functional layer gets shed out because she's not pregnant, then every single month the basal layer is going to help rebuild the functional layer. The basal layer is what attaches the endometrium to the myometrium, and this is the one where you will have the stem cells that will help with regrowth of that endometrial layer every single month. The vagina is an elastic muscular tube that extends between the cervix and the vestibule. It's about 9 centimeters long, but it's highly distensible. So at 9 centimeters, I know some of you may currently be thinking right now in your brain, wait, 9 centimeters and he's not 9 centimeters, so how does that add up? During sexual intercourse, the vagina can expand up to 200%, which is amazing. So it's really, really dependent upon each different female, but it is possible for it to stretch and expand in order to accommodate sexual intercourse. 3 functions include the passageway for the elimination of the menstrual fluids. So keep in mind, it's not the vagina that is actually losing tissue. It's the uterus that's losing tissue on that endometrial layer, but that tissue has to come through the vagina in order to get out of the body. It will also receive the sperm during sexual intercourse, as I previously said, and it forms the inferior portion of the birth canal, so that whenever the baby is being forced out of the uterus by the myometrial contractions of the uterus, it's going to go down the vagina and come out into the world. At least that's what we hope for. It's always a big goal to have a vaginal delivery instead of a C-section delivery, and I'll talk about why later. There are 2 Bobospongiosis muscles that are going to be along either side of the vaginal entrance. The contractions will help constrict the vagina, and they cover the bulb of the vestibule. So this is a mass of erectile tissue on each side. The hymen is going to partially block the entrance to the vagina. This is what's usually torn by sexual intercourse, but it can also be torn for other reasons, not just sex. So whether that's tampon use or intense physical activity, it can tear that hymen, which is just a very thin piece of tissue. Here's a picture where you can actually see the vestibule, and you can see that cervix of the uterus protruding into the vagina. Along the vaginal canal, what you see are these structures called rugae. And so those rugae are muscles that are within the vagina. The rugae are going to be things that not only allow expansion, but can also allow strength. If you've never seen or heard about the people who have the ability to lift weights, I think sometimes up to 30 pounds with their vagina, that's very incredibly interesting. So there can be great strength in this area. Some men really prefer that because that means the woman can really clamp down during sexual intercourse, and some men freak out by that. So you just need to know what your partner likes. On each side of that vaginal canal, you can see that greater vestibular gland, which will lead to some secretions, which help with lubrication. Now, as women get older and things begin to atrophy and hormones begin to change, it is possible for some dryness to occur. So in order to keep sex pleasurable, it's important to have coconut oil in the bedroom. So again, with my favorite oil, the coconut oil, we have 3 jars in our house. So 1 in the bedroom, 1 in the bathroom, and 1 in the kitchen. And I highly encourage all of my patients to have 3 jars because you don't want to intermix and mingle. I mean, you can already imagine how gross it would be to take them from different locations and different places. But coconut oil is incredibly healthy and beneficial, and it's not going to disturb the vaginal pH. Some of those liquids that are sold in order to help with sexual activity between males and females can cause a vaginitis, inflammation in the vagina, bacterial infections. It can cause the pH to be really off, and so it really messes with the female. The coconut oil is not going to do that. It's incredibly healthy to have that inside because it will be nourishing to the tissue. It's antibacterial, antifungal, so it's incredibly safe. So there's no reason for older women to suffer from pain during sexual intercourse whenever it's just as easy as, hey, you know what? Make it good for both of you. Lube him up with some coconut oil, goes into you. It's wonderful, fabulous for both parties involved. So keep it on the bedside stand, and that way you don't have to worry about it. In the bathroom, the coconut oil is great for things like lotion. You can put it on your skin. You can use it as eye makeup remover, regular makeup remover. Use it in your hair in order to make your hair shiny and soft. There's so many things that coconut oil can be used for in the bathroom, in the hygiene department. And then, of course, keeping it in the kitchen to help with things like cooking, utilizing it in shakes or smoothies, using it to saute veggies, whatever you want to do. But that's why I say get 3 so that way it's not really gross, because nobody wants what's been in the bedroom in their fried eggs in the morning. That's just nasty, okay? So 3 jars of coconut oil. My very favorite is Nature's Way. That can be found at Market Street, Sprouts, etc. I have found that to be the best one for multiple different uses. Okay, so within the vagina, because there is bacteria there, it is very, very important to make sure that that flora that is within the vagina stays healthy. Those bacteria are harmless. Not all bacteria are bad bacteria, so it's very important to understand that a lot of our body has bacteria on it, in it, all over. We are more bacteria than we are human cells. So we have to make sure that we take good care of the bacteria that are there to be synergistic with us. The bacteria will create this acidic environment, and that acidic environment restricts the growth of a lot of pathogens. If you have an alkaline environment within the vagina, then you are more prone to have infections. That's something that you absolutely do not want. A general term of vaginitis means inflammation of the vagina that can be caused by a number of different pathogens, whether it's fungus, bacteria, parasites. Again, great for coconut oil to utilize in this particular instance. I have had patients who have come in who have received prescription after prescription after prescription, and what happens is the prescriptions, although they will take away the issue for a small amount of time, those issues will come back with a vengeance and they will become worse long term. The reason why that happens is because things like antibiotics or antifungals destroy the bacteria that's supposed to be in the vagina that is creating the right environment. So whenever you destroy those things that are working with you, then now you can't restrict the growth of those pathogens. So that's why those infections will come back and they will be worse than they were before. So I had one patient who, before she came to me, was on a cycle of antifungal medications monthly for 2 years. Now that is horrendous. So that is a sex life that is non-existent, and it was really emotionally kept her distraught. So in order to help your body and work with your physiology, using coconut oil will kind of help because, again, antifungal, antibacterial, it will really help with making sure that you're killing the things that are bad, but you're keeping the things that are good. So it is possible to utilize that coconut oil and help that process in a natural way. Douching should never be done because douching is going to destroy that environment and it will destroy the flora. So although people think, oh, well, if I douche after my cycle then it cleans things up, very bad to do. You are a self-cleaning mechanism in your vagina. It will clean those things out. If you start to smell things that don't smell good, or if discharge or weird things start to come out, by all means, make sure that everything is correct and everything gets addressed. But there's a lot of things that you can do on your own, whether it's utilizing that coconut oil, using your fingers and sticking it right up in there, or changing your diet, paying attention to how much you're actually drinking water to help flush yourself out because water is absolutely needed. So lots of things that you can do on a natural route to kind of get off of that hamster wheel of prescriptions that make things worse. When you get a vaginal smear, basically this is a sample of the epithelial cells at the surface of the vagina that can be used to estimate different stages of your ovarian or your uterine cycle. So they'll look at it underneath the microscope, see what's going on. Now, whenever I was talking about the coconut oil, I just want to go back to that really quickly and say that has to be a consistent use. That can't be I'm going to do this one time and think that everything is going to go away. That's not the way that it works. So you want to consistently use it until you feel like your symptoms have resolved and everything is back to normal. So just keep that in mind as you maybe utilize that as a natural remedy. If things are not getting better, then by all means, go in, get checked out, because you can't check yourself. It's no real way to kind of get down in there and look. So you do need someone who's going to be able to help you and see if there's a bigger issue going on more than just a pathogen that needs to get out. So again, your vestibular glands are going to secrete fluid during sexual arousal. Again, if that fluid is not there, if she is dehydrated, if the glands have atrophied because of age, decrease in hormones, whatever the case may be, utilizing that coconut oil, again, very healthy, very good, and it's such an easy thing to do. In regards to the breasts, we're looking at mammary glands that are specialized organs of the integumentary system. These will produce milk in order to nourish the infant and of course are under the control of different hormones. So they lie in the pectoral adipose tissue, and both males and females have breasts and have nipples, but it's the females that are going to have that stimulation with the prolactin hormone that are going to help them with lactation in order to nourish the infant. The areola is the reddish-brown skin that is around each nipple. And if you have active mammary glands, then these are going to be because of pregnancy or breastfeeding. Okay, so now we're going to get into the physiological portion of the female reproductive system. And normally whenever I teach this in class, I utilize the entire board in order to draw things out and explain them in step by step. So these are some of the pictures that I have taken from the board from a past class. I try to put the two pictures together, so if it looks a little bit wonky, that's why. But as I walk through and explain what's going on in the physiology of the female reproductive system, you may want to refer back to this chart so that way you can kind of keep everything organized and straight. In the male reproductive system, what you see over on the left-hand side, in regards to spermatogenesis, it was incredibly straightforward. It was, primary, secondary, spermatid, sperm, and we were there. However, in the female, we are complex creatures, and there is a lot of stuff that is happening all at the same time. So because this is all occurring concurrently, it makes it difficult to learn and sometimes understand some of these things whenever you are first finding out about exactly all of the different processes that are occurring. In the female, remember, we have to think about what's going on in the hypothalamus, the pituitary, the ovary, the uterus, all at the same time. So in the ovarian cycle, that's what you see in the green, where you see primordial, primary, secondary, etc. Those are going to be the things that are happening inside of the ovary. And then what you see over in the red, where it says menstrual proliferative secretory, that's what's happening inside of the uterus. So that's going to be part of the uterine cycle. However, what you see in the primordial arrow over towards the primary oocyte, that is going to be occurring inside of the ovary within the follicles that you see listed in the green. So I know that's quite confusing, but as we walk through this and work through it, if you need to pause or take a moment to come back to these slides, then I do encourage you to do that because it can get quite complex as everything is occurring all at the same time. So as we walk through this process, just know that this oogenesis is going to begin before birth. In males, spermatogenesis started at puberty. Now, oogenesis is going to begin before that baby girl is even born into the world. It will accelerate at puberty, and then it will end at menopause. And there is no hard and fast rule for menopause. It's anywhere from 40 to 55 years of age, just depending on that particular woman. Now, remember, in males, they have the ability to continue to go through spermatogenesis and produce sperm beyond the age of 70. So there's a lot of differences that are occurring in the spermatogenesis versus the oogenesis. For the stem cells within the female ovary, those are called oogonia. Remember, in the male, it's called spermatogonia. So the words are still kind of similar, but the oogonia are going to have to undergo mitosis in order to give us the diploid primary oocytes. At this point, we have about 7 million primary oocytes after 5 months of development. So she's still in mom's womb, but oogenesis is occurring because the oogonia are undergoing mitosis and we're getting our primary oocytes. You can see here our oogonium, which is our stem cell, is going to, just as it did in spermatogenesis, we're going to have one that will stay in oogonium, one that will become a primary oocyte. Remember, we have one that needs to stay in oogonium, stay a stem cell, so we can continue to do this process over and over and over and over again. And remember, mitosis gives us an exact replication. Okay, so we've got our primary oocyte, which is diploid. At birth, once she comes out of the womb, the ovaries now contain approximately 2 million primary oocytes. So we just went from 7 million to 2 million. That's because most of them will degenerate in a process that's called atresia. So we've decreased the numbers, and what is remaining, those 2 million, are suspended in prophase 1 until she hits puberty. But by the time she hits puberty, she no longer has 2 million. Now she has about 400,000 primary oocytes. So somewhere around that 400,000 number is all she's going to have to work with her entire life. That's it. You do not get more. Males get to make more every single day. Females get a specific number, and then once you're out, you're out. That's it. Okay, so of those 400,000 primary oocytes, some, not all, some are going to be stimulated to finish meiosis 1, which will produce our haploid secondary oocytes. Because remember, meiosis is all about sex cells and decreasing the chromosome number to half. So we need haploid secondary oocytes. It's no longer 2N, now it's just N. So here's your picture for that. The primary oocyte is going to divide. And as it divides, what we're going to get is we're going to get a secondary oocyte and a first polar body. So that secondary oocyte, make a note right here, very, very big. Okay? When you look at the first polar body, write a little note over there that says no function. Basically, the reason why we're needing to separate these is for the purposes of chromosome division. But that first polar body is not going to serve any function beyond just taking those chromosomes away so that meiosis can do what it's supposed to do. The secondary oocyte is massively large for a reason. Because if that secondary oocyte gets fertilized by a sperm, ultimately that's going to become a baby. So as much cytoplasm as possible, as much organelles as possible, gets shifted over into the secondary oocyte so that it can nourish that growing and developing baby until mom has formed a placenta, which will then kind of take over. So there's a lot of steps that happen in between the fertilization and the development of the placenta, but that's just one of the reasons why that secondary oocyte has to be so large, is because it is what will be fertilized and then ultimately become a human being. So the secondary oocyte is actually so big, you can even see it with the naked eye. You don't even need to use a microscope to look at the secondary oocyte, which is incredibly cool. Okay? So primary oocytes will remain suspended in development until puberty. Remember, she has about 400,000. Once puberty hits, then that FSH is going to be released from the anterior pituitary, and that is going to start the ovarian cycle. So each month after the ovarian cycle begins, some of those primary oocytes are going to be stimulated to become the secondary oocyte and the first polar body. We cannot get to the secondary oocyte until she hits puberty, until that FSH is released by the anterior pituitary gland to stimulate this to move on to the next step. Okay? So, as I already said, the cytoplasm is going to divide unevenly, so we've already kind of talked about that a little bit. When we look at this next step here, what I want you to see is the secondary oocyte is what gets released at ovulation. So maybe circle that or highlight that, because we're going to say that over and over again. So it's going to be important to remember that when a female ovulates each month, what she's actually releasing from her ovary is the secondary oocyte. The secondary oocyte is the thing that is going to travel through the fallopian tube and quite possibly meet up with the sperm. Now, obviously, if she's abstinent, that's not going to happen, right? So if she's abstinent, she's going to get her cycle, and what is going to come out in the cycle is going to be the secondary oocyte. If, however, she is sexually active and is trying for a baby, then what can happen is the sperm can meet up with that secondary oocyte and then fertilize it. At the time of fertilization, that secondary oocyte now becomes what we call an ovum, O-V-U-M. And that's what a lot of people will refer to as the egg. But you don't actually get the ovum unless fertilization occurs. And just because fertilization occurs doesn't mean you're going to get a pregnancy, because there's so many other things that have to happen. So what you see in this picture is that sperm is penetrating through the secondary oocyte, and you can see the genetic material from dad can now combine with the genetic material from mom and then give us a baby. So again, that process of oogenesis, the primary oocyte will remain in suspended development until puberty, and then at puberty, that FSH can trigger the start of the ovarian cycle. And each month thereafter, some primary oocytes are stimulated to develop further. Some of them may continue to go through meiosis in order to become that secondary oocyte. So now let's talk about the follicles. Okay, so we just explained how the oocytes within the baby are actually starting production before she's even born. By the time she's born, she has millions, but by the time she hits puberty, around 400,000. Those oocytes are actually going to live inside of these follicles. So think about the follicle as a house. That's the analogy we're going to use right now. So the follicle, or the house, is what contains the actual oocyte. Okay? So these follicles are specialized structures within the cortex of the ovaries, and this is where the oocyte growth and the meiosis actually occur. So for primary oocytes, these are going to be located in the outer part of the ovarian cortex in clusters called egg nests. The very smallest house possible is called a primordial ovarian follicle. Within the primordial ovarian follicle, you will have the primary oocyte. Okay, again, the follicle is the house to the oocyte. As FSH is secreted, what is FSH? Follicle stimulating hormone. Follicle stimulating hormone. The FSH is going to cause these follicles to grow larger. So from a primordial follicle, we can then get a primary follicle. That primary follicle is going to get a structure that we can now see that's called the Zona Pellucida. And I'll show you a picture in just a minute. If it's continued to grow, then it becomes a secondary follicle. Continue, and it will become a tertiary follicle, aka Graphian, aka vesicular. So there's 3 names for this tertiary follicle. But this is the growth that we want to occur so that everything works like it's supposed to. The primordial follicle, I want you to think about it as a little tiny shack. And then the primary, the house gets a bit bigger. And then in the secondary, we've got a very large house. The tertiary, we've got a mansion. This thing is now huge, okay? So we've gone through the process of growth, and our house has become bigger and bigger and bigger and bigger. Now, the key here to remember is not all follicles are going to grow to the tertiary size. even if they start the growth, let's say they go from primordial to primary, that does not necessarily mean that they're going to make it to secondary or tertiary. So we can have a lot of follicles that can start to grow up. However, ultimately, every single month, we're just going to have one that's going to get to the size of the tertiary follicle. So think about it this way. There's a lot of people who would really love to live in a mansion, but they don't. Not everybody gets to live in a mansion. Not everybody makes it to that level. Same thing happens in the ovary. Not every single one of those follicles is going to make it to that big, huge size. Okay? So whenever we have the tertiary follicle, star this, the tertiary follicle is now going to contain the secondary oocyte. If it grows to this size, that means enough time has progressed to develop this from a primary oocyte into a secondary oocyte. Because remember, the oocyte lives inside of the house. So if we get a big tertiary follicle, we've got a secondary oocyte at this point. That tertiary follicle will create a little bulge inside of the ovary. The oocyte and its follicular cells will project into what we call the antrum. So this is the central chamber of the follicle. They will be surrounded by what's called granulosa cells, and then cells in the adjacent ovarian stroma will form fecal endocrine cells that produce estrogen. So here we're starting to see our levels of estrogen and where they can come from. We know that as a girl hits puberty, her levels of estrogen begin to increase. And so, with that, the reason why is because the follicles are now growing up. Rising LH levels will prompt the completion of meiosis 1. So, FSH is responsible for growing up the follicles. LH is going to be the thing that prompts the completion of meiosis 1. And I'll show you in a bit what that huge peak in LH is going to do inside of the ovary. The corona radiata, which basically means radiant crown, I absolutely love that term. The radiant crown are going to be the granulosa cells that remain associated with the secondary oocyte whenever she ovulates. So let's take a look at some pictures here. Remember, the primordial follicle is your shack. It's your tiny little house. Remember, inside of the house lives the primary oocyte. So here in this picture, what you can see is the primary oocyte living inside of the tiny little house, the little follicle. What is the hormone that is going to stimulate this follicle to grow up? FSH, which comes from the anterior pituitary. Under the influence of GnRH, which comes from the hypothalamus. So, if that FSH goes and stimulates this primordial follicle, it's going to grow up. And the next stage of growth is called the primary follicle. So we went from primordial to primary. Now you can see the house getting bigger. You can see that the primary oocyte is still inside of the ovarian follicle. And now you see that structure that we called the Zona Pellucida and the granulosa cells as well as the thecal cells. So now our estrogen levels are going to start to increase because of this growth. As we grow and we go into the secondary ovarian follicle, now you see that it's even larger, it's even bigger. We still have the thecal cells and the granulosa cells that are in this area, so our estrogen levels are going to continue to increase. And then lastly, we get to the mansion. Remember, not all follicles will make it here. So not everybody gets to live in the mansion, but whoever does get to live in the mansion is now going to be the secondary oocyte. And at this point, we now have fluid inside of this follicle. The granulosa cells, you can see, are still surrounding that secondary oocyte, and now you can see the corona radiata. So if we look at this on an ovary picture, and there is a model that looks just like this in the lab where you can see this exact same thing, where you see the tiny little primordial ovarian follicles, and then you start to see them grow into primary and grow into secondary and then grow into tertiary. The tertiary is the mansion, the biggest it can possibly get. Remember, the AKAs are Graafian or vesicular. There is fluid inside of that tertiary follicle. The tertiary follicle contains the secondary oocyte. The secondary oocyte is what is going to be released when she ovulates. So what you see on the picture down at the bottom of ovulation is the secondary oocyte that is rupturing through the ovary. It is coming out. For females who can feel a little bit of cramping or a little bit of pain around day 14 of their monthly cycle, they are actually feeling the secondary oocyte ripping out of the ovary. Not everybody feels it. It's not bad if you feel it. So it's more common for people to not feel it than for people to actually feel it. But if you're pretty in tune with your body, it's more likely that you're going to feel that ovary being released from, or that secondary oocyte being released from your ovary. And when it is released, the corona radiata will go with it. The corona radiata will surround it, and that is going to have to be penetrated by the sperm if it's going to make it into fertilizing the egg. It has to get through all of that first before it can actually penetrate and fertilize. So, whenever we look at the growth from primordial to primary to secondary to tertiary, because that is all follicle, 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 we call that the follicular phase. And the follicular phase of the ovarian cycle is under the influence of follicle stimulating hormone. So if you just keep everything together, it makes it a whole lot easier to remember. Follicle, 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 under the influence of FSH, that is the follicular phase of the ovarian cycle. Once ovulation occurs, now we're going to be talking about the luteal phase. So what you see happening in the ovary after that secondary oocyte is released, now the follicle, which is now empty, transitions into what we call the corpus luteum. So that is where that word luteal phase comes from. The thing that makes the secondary oocyte be released from the ovary is a surge of luteinizing hormone. So there's a massive surge of LH that is going to occur once you have a secondary oocyte inside of a tertiary follicle. That massive surge of LH causes the secondary oocyte to leave its home, it leaves its mansion, and goes out to try to find its way into the fallopian tube. Okay? So, follicle growth and development occurs within days 1 through 14 of the ovarian cycle. We call that the follicular phase. Once the LH peak hits on day 14 and ovulation has occurred, we now are going to transition into the luteal phase. So remember that L from luteinizing hormone is associated with the L for the luteal phase. The luteal phase is going to have the structure of corpus luteum, which is going to be very important if she is trying to become pregnant. So we'll talk about that next. Okay, so just to recap, everything that I just said on that picture is in this slide right here. where we're talking about the difference between the follicular phase and the luteal phase. Just remember, follicular phase is under the influence of FSH, luteal phase is under the influence of LH. So ovulation is when that tertiary follicle releases that secondary oocyte into the pelvic cavity. Because remember, the tube is not connected to the ovary. So that secondary oocyte ends up in the pelvic cavity. And the reason why the uterine tube has those finger-like structures at the end, those fimbria, is because it tries to call the oocyte over into it. So it kind of like waves its fingers, like if you kind of wave your fingers and tell someone to come near you. That's actually what the fimbria is going to do. So it's going to try to get that oocyte to come into the uterine tube. This can be one of the issues with infertility. If that if that secondary oocyte never gets into the tube, it's not going to be fertilized. So we've got to get it over into the tube. Any of the ovarian follicles that started their growth and development but did not complete, they never made it to the mansion stage, they are basically going to undergo atresia, and that's it. You don't get to use those anymore. So just for easy numbers, just to make it very simple for you, if you have 100 that start and only one makes it into the tertiary phase, then you just lost 99 opportunities to have a baby. So this is why when women say you really want to pay attention to your age and your time frame, because every single month you're going through the growth and development of these follicles, but once they begin the process, if they don't finish it, they will go through atresia and you do not get to reuse them. That's not how it works. Okay, so for our luteal phase, that corpus luteum is incredibly important because this is going to form and it's going to help create progesterone. So in the follicular phase, we talked about how estrogen is going to increase because we have those thecal cells, but now the corpus luteum is going to help increase progesterone levels. This is yellow in color because of cholesterol. Remember, cholesterol is vitally important in order for us to make our steroid hormones. So we learned that in the endocrine PowerPoint. Got to have the cholesterol in order to convert this into progesterone. If a woman does not have sufficient levels of progesterone, she is not going to be able to carry to term. So when I'm working with my infertility patients, I have to make sure she has plenty of healthy cholesterol so that she can make that progesterone. If I need to support her progesterone levels, then I have to ensure that that is being done so that the uterus is properly prepared for pregnancy and she has successful implantation. Okay, so progesterone levels are going to be vital whenever it comes to successfully carrying a baby to term. For people who get pregnant and then they weren't even trying, didn't even realize it, and they're like, oh, my cycle just stopped, let me check and see if that's the reason why. When they go in for their first appointment, the doctor is always going to check progesterone levels because they know that if her progesterone levels fall at any point in time, she's going to miscarry. So those progesterone levels need to grow higher, 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 higher as she is going through the first few weeks of her pregnancy. They cannot drop. If they drop, she will miscarry. So it's incredibly important to have proper levels of progesterone, but you can't have it if you don't have healthy cholesterol. So in addition to the progesterone, the corpus luteum will secrete just moderate amounts of estrogen. If she does not get pregnant, then that corpus luteum will begin to degenerate about 12 days after ovulation, because there is a signal that says there is no baby that has implanted. We got to start this process all over again. So the corpus luteum will degenerate, progesterone levels will decrease, and the corpus luteum is going to transition over into scar tissue. So here's a picture of the corpus luteum underneath the microscope. If it transitions into scar tissue because there is no pregnancy, we call it the Corpus Albicans. If you get the Corpus Albicans, then that means this is the end of the ovarian cycle. Both the progesterone levels and the estrogen levels are going to plummet. And whenever they plummet, this is going to be a signal for the uterus to shed because there is no baby, so the endometrial layer will go away. This is what the Corpus albicans looks like underneath the microscope. It's the scar tissue. So yes, this scar tissue will be built up inside of the ovary as the woman goes through this process every single month. So that is the ovarian cycle. Let's recap real quick so that you're okay. The ovarian cycle is divided up into the follicular phase and the luteal phase. Follicular phase is all about the growth of the follicle. We move from primordial to primary to secondary to tertiary under the influence of FSH. The thing that lives inside of the follicle is the oocyte. It's a primary oocyte until you get to tertiary follicle. Once you're at tertiary follicle, it has differentiated into a secondary oocyte. The secondary oocyte is released at ovulation under the influence of a massive peak of LH that comes from the anterior pituitary gland. The secondary oocyte is released out of the ovary, surrounded by the corona radiata, into the pelvic cavity, and hopefully will be picked up by the fimbria of the uterine tube. Back inside of the ovary, that empty house now transitions into the corpus luteum. The corpus luteum is going to be rich in cholesterol so that it can make the levels of progesterone that are necessary for the last half of the cycle, the luteal phase of the ovarian cycle. If there is no baby, the corpus luteum will degenerate and turn into scar tissue, which is called the corpus albicans. At that point, both progesterone and estrogen levels fall, and it signals the uterus that it's time to shed that endometrial layer, which then gives us our menstrual cycle. So here we are with our uterine cycle, which is a repeating series of changes within the endometrium. Because it's easiest to use the textbook 28 days, we're going to use 28 days as we're learning this, although some women have shorter or longer cycles. It's very important for every woman to track how long her cycles are, so that way she knows whether she's a 22-day, a 28-day, or a 32-day, or whatever it is, and just kind of keep up with things. Menarche is the very first uterine cycle that occurs when she hits puberty, which is generally around age 11 to 13. Menopause, the pause, is the termination of the uterine cycles, which can happen anywhere between, according to the book, 45 to 55, but because people eat so bad and go through so many stressful life events, menopause has started to get younger and younger and younger, and some women as young as 40 are now going through menopause, which is not always a great thing. So, the menopause is the termination of the uterine cycles. Perimenopause is the time frame where cycles get really wonky, and maybe you have 2 and then you skip 3 months, and then you have 2 more months of cycles, and then you skip the whole rest of the year. So perimenopause is when you start to see that your cycles are no longer consistent on a monthly basis, and it's not because of pregnancy. It's because the follicle number is getting really low and you're not able to grow up your follicles on a monthly basis anymore. When there are no more follicles left to grow up, that is when you hit menopause. So however many years it takes you to get there, which is why there's a big span of difference between the different age groups in menopause for different women. The uterine cycle is divided into 3 phases: the menstrual, proliferative, and secretory phase. The menstrual and proliferative phases are going to occur during the ovarian follicular phase. So remember, this is complex because there's so many things happening concurrently. In the uterus, the menstrual phase and the proliferative phase are occurring when the ovary is trying to grow up the follicle, so in days 1 through 14. The secretory phase of the uterus is occurring whenever the ovary is in the luteal phase, so days 15 through 28. Again, if you need to go back to those pictures of the board, go back to those pictures so that way you can look and you can see how everything kind of works together. In the menstrual phase, what's happening is that endometrial functional layer is degenerating, and this is what is going to lead to the menstruation. What happens is there is constriction of the arteries that are going to that endometrial layer that will reduce the blood flow, oxygen, and nutrients. Obviously, if you do not have oxygen, blood, and nutrients going to a tissue, that tissue is going to die. So that is what is happening here. The restriction is caused by a plummet in those hormones. So it's a sign that the endometrial layer can no longer be maintained. So those arteries restrict, and the weakened arterial walls will start to rupture, and this is what is going to lead to the release of blood into the connective tissues of the functional layer, and it will come out as blood in her monthly cycle. So the entire functional layer is going to be lost. It will come out through the cervix and then out into the vagina in order to come out of the body. Remember, only the functional layer is going to be affected, and that deeper basal layer is going to be the one that will help rebuild the functional layer after she is done menstruating. This can last anywhere from 1 to 7 days. Ideally, you don't want to have this last longer than 4 to 5 days. Holistically, we say that it's best for it to be just 3 to 4 days. And anything beyond that, we need to kind of see if there's some deeper things going on. Some women have cycles up to 10 days. I used to be one of those people. If you are having 10-day cycles, 11, 12 days, that is definitely a problem. There is certainly something wrong. I personally grew up eating really, really, really bad foods. So my mom was always busy. She did not know how to cook. She still does not cook. So we ate out at every single meal. Eating out at every single meal, well, if I ate at home, it was like breakfast, Fruity Pebbles, Lucky Charms, Frosted Flakes. Those were our favorite cereals. So I basically ate crap all day long. I ate lunch in the cafeteria, and then at dinner time, we would either go to Pizza Hut or Popeyes, Red Lobster. It really just depended upon what my mom wanted that day. After I left my mom's house, I didn't eat pizza for like 7 years because I was so sick of it. So I ate really, really bad foods for the first 20 years of my life. And it wasn't until my mid-20s whenever I started changing things. But my cycle was always incredibly bad, and that's because I had really unhealthy foods in my system that were not nourishing nor supporting my reproductive organs, and it was actually causing a lot of dysfunction. In addition to bleeding for too long, some women bleed way too much. On average, you should lose 35 to 50 milliliters of blood in your cycle. It's hard for some women to measure how much they are losing, though, because they do not utilize anything that will help them with measuring. Whenever I found out about menstrual cups, which we'll talk about at the end of this PowerPoint, I was incredibly happy because this gives you the ability to measure. And even though I was going to the OBGYN and complaining that my cycles were lasting way too long and they were way too heavy and I was having intense amount of blood loss, the doctor told me, oh, yeah, that's normal. Again, why I want you guys to know, just because something is common does not mean it is normal. And her solution to me was, well, I can put you on birth control. That really wasn't what I needed, although that's what I did because I knew no better whenever I was a young kid. So I got started on birth control very early because of multiple issues in my reproductive system. Now that I know better, I will never allow that to happen with my daughter because we're going to treat the problem instead of just covering it up with the Band-Aid and hoping that things work themselves out. So when you have dysmenorrhea, this could be painful menstruation, which has several different causes, which was also one of the things that I dealt with. Cramping, pain, bloating, etc., etc. The more symptoms the woman has as she's going through her cycle, the more support that she is going to need. So whether that is just situations with really bad food choices, or whether it's something as severe as endometriosis, which causes extreme pain. Thank God that was not my case. But I've worked with some endometriosis patients, and it is a very, very painful condition. So we want to address that in women and make sure that they know what's going on with their system and support them in all the ways possible to help with whatever is causing them dysmenorrhea. Okay, so here's pictures of your uterus and the different layers. You can see here in the myometrium, the basal layer, and then the endometrium, you can see those glands. So remember, the endometrium during the menstrual phase of the uterine cycle is trying to shed that functional layer, and the basal layer will be what is rebuilding that endometrium. In the proliferative phase, there are epithelial cells of uterine glands that are going to multiply and help restore the integrity of the uterine epithelium in order to completely restore the functional layer. So think about proliferate. We're going to proliferate the endometrium. This occurs at the same time as the enlargement of that tertiary ovarian follicle that we've already discussed. So this is stimulated and sustained by estrogen that gets secreted by those developing ovarian follicles. So remember, those thecal cells were helping us with secreting that estrogen. As those follicles are growing up and secreting that estrogen, this estrogen is allowing that endometrial layer to proliferate and rebuild. The entire functional layer is highly vascularized. Obviously, there's a lot of blood flow that's going to be going into this area. So whenever we look at the proliferative phase, keep in mind we're trying to rebuild this uterus to look like a fluffy pillow. Okay, that's the goal, because this is where the baby will live for 40 weeks. And if you have the opportunity to choose between a nice, comfy, fluffy bed that is incredibly comfortable versus a cement block, you're definitely probably going to choose the comfy bed. If the baby is going to have to live here for 40 weeks, you need it to be nice real estate. So we have to help proliferate this uterus so that the baby can implant, feel comfortable, grow, and develop as it's supposed to. So here you can see the endometrium during the proliferative phase. It's growing thicker, it's proliferating so that we can get that fluffy pillow, so that we have that nice real estate for that future kid. In the secretory phase, this is where we have the uterine glands enlarging and increasing the rates of secretion of progesterone to prohibit the endometrium from breaking down. It will also help accumulate energy sources in the form of glycogen and then provide more surface area within the spiral arteries. Those arteries can elongate and go all the way through the functional layer, because if the baby is going to implant successfully, the first thing that it's going to do at implantation is tap into mom's blood supply. That is one of the keys of successful implantation, is does the baby have the ability to access mom's vascular supply, because it's going to need those good oxygen and nutrients, because remember, it does not have a placenta yet. So it's going to have to get its nutrients from mom. That's very, very, very important. So this is what's going to be happening in the secretory phase. So not only do we have a fluffy pillow, we basically have the areas where baby can tap in and get lots of good support and nutrition in order to maintain that pregnancy. Now, if you also remember, progesterone is necessary. That progesterone will prohibit the endometrium from breaking down, which is why it's vitally important that women who become pregnant have good levels of progesterone so that we can maintain this endometrial layer for that baby. This secretory phase will generally last for 14 days, and if there is no implantation, then it will get the signal from the Corpus Luteum that there's no implantation. Corpus luteum is transferring over into corpus albicans. There's no more hormones. Again, estrogen, progesterone levels plummet and they drop, and we go back through the menstrual phase all over again. So every single month, as the ovary goes through its process of growing up follicles and releasing a secondary oocyte in ovulation and making progesterone in the luteal phase, the uterus is also going to be going through its own processes. It's going to be getting rid of old, so that way we can have healthy and new for the baby. It's going to be building up a pillow, and then it's going to be going through the secretory phase, so that way we are ready for that baby and we're prepared to make it a successful pregnancy. If there is no pregnancy, then we're going to shed it all off in the menstrual cycle and do it all over again. And so this is what happens every single month as she goes through her cycle. So here you can see the endometrium during the secretory phase. Now it's really built up, and then you can see those uterine glands within that functional layer. Lots of good blood supply that the baby can tap into. Alright, so this female reproductive cycle, again, it's controlled by hormones of the pituitary gland, so the FSH and the LH, and then also from the gonads, so that would be the estrogen and the progesterone. This is a very complex pattern, and I tried to make it as straightforward and as simple as possible in explanation. If that picture is not helpful, you can also utilize this video right here to kind of walk through the different parts of the female reproductive cycle in order to help you understand all of the different processes that are occurring concurrently. Okay, so some of these following slides are just going to be repetitive of things that I've already said as we've gone through this, but sometimes it's helpful to hear it more than once. So just keep in mind that FSH from the anterior pituitary is going to stimulate follicular growth and development. And as those follicles enlarge, the thecal endocrine cells are going to produce what's called androstenedione. This is going to be absorbed by the granulosa cells, which can then be converted to estrogen. So that's where we're actually going to get our estrogen from. Those thecal cells will secrete the estrogen, and the estrogen is bound primarily to a protein called albumin. There are three types of estrogen. We have estradiol, estrone, and estriol. Estradiol is the most abundant estrogen and has the most pronounced effects on target tissue. So this is the dominant hormone prior to ovulation, because remember, we're growing up the follicles under the influence of FSH and helping to create those estrogen levels higher and higher. And estrogen synthesis is because the androstenedione is converted to testosterone, and the aromatase will convert the testosterone to estradiol. So keep in mind, as we walked through the PowerPoint for males, it is possible to have that testosterone convert over into estrogen. Estrone and estriol are synthesized directly from androstenedione. Here is the little picture that basically will show you the necessity of cholesterol as the precursor in order to get the progesterone, the androstenedione, which will convert over into estrogens, and then the testosterone in males can convert to either the DHT or sometimes even into estradiol. But the primary pathway in females is going to be for the androgen to convert over into the estradiol. 5 functions of estrogen include stimulating bone and muscle growth. So whenever you're looking at older women who go through menopause and they no longer have those higher levels of estrogen anymore, sometimes they want to go on hormone replacement therapy, and people talk about bone health and the necessity of estrogen for good bone health. However, hormone replacement therapy can be very damaging. It has been linked to increased incidences of estrogen-dominant cancer, so you do have to be cautious with that. I always encourage people to exercise and use physiology to your advantage. Wolff's Law says that if you increase the pressure on bones, then you will stimulate bone growth. So exercise, get out, be active, do something. Walk with the ankle weights on your ankles or wrist weights on your wrist, like as you pump your arms and you move your legs. Go swim, do something that is going to help with stimulating that bone and muscle growth. Maintaining female secondary sex characteristics, of course, are a part of estrogen, so this is going to help body fat go in all the right places, whether that's in boobs or butt or wherever it's supposed to be. That's part of the female secondary sex characteristics, is to have that lovely little shape. It will affect the central nervous system activity, especially in hypothalamus, where estrogens have the ability to increase the sex drive, which is why sometimes, of course, after menopause, besides the dryness and the pain, the decrease in that estrogen may also decrease the drive as well. Again, things to do that we can help women in that particular age group so they don't have to feel like they're missing out or disappointing a husband, because that's always emotional as well. And then maintaining functional accessory reproductive glands and organs, as well as initiating repair and growth of that endometrium, as we have already discussed. So estrogen is important, but it is very, very, very important to remember that estrogen and progesterone always need to stay in a balance with one another. You do not want to have massive amounts of estrogen and very low amounts of progesterone, because that leads to multiple issues inside of the body. If you are not familiar with estrogen dominance, I highly encourage you to look that up. Look up the signs and the symptoms, because I guarantee you know multiple people who are struggling with estrogen dominance, but they don't even know it. So look up estrogen dominance, start talking to people. Again, use your knowledge of your newfound anatomy and physiology material to your advantage to help you as you learn to communicate efficiently with people. They'll ask you questions and you won't always know the answer, but that's good, because experience is the best teacher. It'll force you to go and look up things. And it will force you to, oh, okay, well, that makes sense. That's the answer. So now I can put that together. And now if somebody asks me in the future, now I know the answer. So it will be really helpful to you. Do not feel like you have to know every single thing. I have been doing this for years, and I still don't know every single thing. So I like it whenever I get questions asked, because if it's a, oh my gosh, I never considered that before, it makes me go research and to look into things, which only helps me help more people in the long run. So you don't have to know everything. Hormonal regulation of the luteal phase, as we said, this is under the influence of high LH levels to promote that progesterone secretion and trigger the formation of the corpus luteum. That LH will maintain that corpus luteum, and remember that corpus luteum has to have the progesterone because it has sufficient amounts of cholesterol first. In the luteal phase, the progesterone levels remain high for about a week, and then unless the pregnancy occurs, that luteum will degenerate, progesterone and estrogen levels drop, as I've already said. Whenever they drop, then this is a sign that we are starting over in the cycle. So yes, you're going to have menstruation, but it's also a sign that the hypothalamus is going to say, okay, it's time for us to begin this all over again. So the GnRH will come out of the hypothalamus in order to stimulate FSH secretion so that we can begin again with growing up that primordial follicle and getting it to that mega mansion. This is a chart that I absolutely love. If you like looking at charts and they help you to learn, I highly encourage you to take note of which slide this chart is on. There's also another chart that is associated with this. So this will show you, as you can see on the top there, you have gonadotropic hormone levels, so you know that this is going to be coming from the brain. So the very first row of this chart is all about what's occurring in the brain. Where are the FSH levels from days 1 through 28? Where are the LH levels from days 1 through 28? Where's the GnRH levels? So that is what you're seeing in row number 1. Row number 2, you're looking at the follicle growth and development inside of the ovary. So that's what you're seeing there as you move through the different stages of growth of the follicle, ultimately to get your ovulation at the same time as your LH peak, and then move through the luteal phase. Because of the growth of the follicles, remember, estrogen is going to be the dominant hormone pre-ovulation. Post-ovulation, progesterone is going to be the dominant hormone. So that's what you're actually seeing in that third column there. And you can see down towards the end of that column on days 28, then you have all of those hormones, progesterone, estrogen, and inhibin, all plummet. And that is then what causes the signal to say, okay, it's time for the menstrual cycle to begin. Now, sometimes there are some women who struggle with proper production of hormones and they don't have hormone levels that look like this chart. That's where things like PMS come in. So if you look at this slide right here, what you are looking at is the pink is supposed to be representative of your estrogen levels, and then you have your purple, which is representing your progesterone levels. Whenever you look at the little dotted line, what you're seeing here is that these dots are not lying right on top of the pink and the purple. So this is an actual test from a patient who has PMS. This is a salivary test that's measuring both her estradiol and her progesterone levels. And as you can see, she's having dips where she's not supposed to have dips, and she's not even raising to the level where she should raise. So even in the flatlining, you can see there that that is not how things are supposed to occur on a monthly cycle. So whenever you have patients who are struggling with all of the different symptoms of PMS, sometimes a very easy test to run is just a salivary test that will determine where are her levels of progesterone and estrogen as she goes throughout her cycle. Blood labs only show something that is one point in time, and hormones are very complex and they can change by the day. So just looking at a one point in time sample doesn't always help show the entire picture, which is why you would want to work with someone who is familiar with holistic healing, not just someone who is going to look at a one shot in time test and determine that, oh, well, it falls within these huge ranges, because in the blood labs you will see that the ranges for the follicular phase, the luteal phase, they are very large. So a lot of women do end up within the normal range, even though they are struggling and having problems. So this is a better way to run those tests to kind of help see what's going on with the patient and how to best help them. There are a number of different herbs that can be utilized. Again, why you would want to work with a holistic practitioner to help with regulating your levels appropriately and not causing any further problems. Alright, so again, recap hormonal regulation of the uterine cycle. When progesterone and estrogen levels decrease, this is because that corpus luteum is degenerating and it will result in the menstruation. So the endometrial tissue will shed for several days. Again, we hope that it's not more than 3, 4, maybe 5 days until the rising levels of estrogen stimulate the regeneration of the functional layer. That proliferative pillow building phase will continue until the rising progesterone starts the secretory phase. And when we have an increase in estrogen and progesterone, it will cause the enlargement of the uterine glands, increase the secretory activity of the endometrium, and help prepare the uterus for the implantation of the baby. Body temperature will fluctuate according to where she's at in her cycle. So during the luteal phase, we already know that progesterone dominates, and during the follicular phase, estrogen dominates. And basal body temperature will be different during these phases. So upon ovulation, the BBT will decrease briefly, but a day after ovulation, the temperature will rise and then remain high throughout the luteal phase. You can see that on the chart here. So this one is associated, look at the very bottom row, you can see the BBT is going to dip a little bit before ovulation, but after ovulation has occurred, you can see how sharply it will rise. Now, when I am working with people who are infertile, one of the things that I do like them to do is to watch their temperature. And there are ways that you can do this. There are even devices that will do this for them. so that they don't have to worry about making mistakes or anything of that nature. So there are things out there to help with monitoring that BBT. It always has to be done in the morning before they even get out of bed and do a single thing. Before their foot even hits the ground, that BBT has to be measured. So for people, especially with PCOS, this is going to be a little bit more difficult to do because PCOS, polycystic ovarian syndrome, is going to cause an abnormal issue with LH, and it is going to cause some temperature fluctuations, which will not be present in people who do not have PCOS. So that's a completely different ballgame in and of itself, but it can certainly still be addressed. I've definitely done it before, and it was successful. It just takes time. Anybody with PCOS is going to take a whole lot longer than somebody who does not have that process occurring. Endometrial changes during the uterine cycle are in the top row, so you can see there the follicular phase of the ovarian cycle is associated with the menstrual and proliferative phase of the uterine cycle. And you can see that secretion by the uterine glands in the secretory phase. Look at those blood vessels as they really get large and they are getting ready to allow baby to tap into mom's blood supply whenever it implants. Again, that luteal phase is highly dependent upon high levels of progesterone in order to prohibit that endometrial lining from breaking down and maybe sloughing off too early. Alright, so now we are in part 3, so some of the fun stuff. On this particular slide, I just couldn't help whenever I saw this picture of these period panties. That was so funny to me. So I just had to put that in there. That has absolutely no rhyme or reason to this PowerPoint, but the cups do. So what you see in the top right-hand corner are different types of menstrual cups. All females are a little bit different in size. If you have not had a baby, it's going to be very different versus someone who has had 4 babies. So whenever you're looking at cups, it's very important to try a few before you actually just give up on one because you got the first one wrong. Cups are phenomenal, and I highly recommend that people switch over to cups, especially if they have cycle difficulties, if they have longer cycles than normal, and if they have heavier cycles than normal, and if they have pain. Those are the top 3 reasons why you would want to switch over to cups. And I'll tell you, these cups are made from silicone, so they are not laced with chemicals that are going to negatively affect your reproductive organs. If you are not familiar with all of the negative things that go on with the making of non-organic feminine hygiene products, then you need to do some research. Especially if you're utilizing them on a monthly basis, you need to know what you're putting up in your hoo-ha or what you're putting around it. It's that important because that vaginal tissue is so permeable and it will absorb lots of different chemicals, things that you don't want it absorbing from tampons that you may be sticking up there for 20 years of your life. So look into it. Switch over to organic. If you're not willing to utilize a cup, at least switch over to organic so that you're not exposing yourself to very toxic, heavy chemicals. Whenever you look at the cups, one of the other benefits of them, especially for people who have abnormally heavy flows, is that it can measure. If you go to the gynecologist and you tell her, well, I have a really heavy cycle and I'm going through lots of tampons on a daily basis, there's no way for her to quantify that. And remember, in America, they want to quantify everything. So if she can't quantify, if he can't quantify, then you may hear those dreaded words, oh yeah, that's normal. We can put you on birth control. And that's really not the direction that you want to go in because of what birth control can do to negatively impact your hormones. I'll talk about that in a minute. But these cups can measure, so there are different size cups with different measurements. Some cups can hold up to 30 milliliters, and if you are going and emptying that cup 5 times a day, then that means you're losing 150 milliliters a day, and if you are bleeding for 10 days in a row, if you take those facts to your gynecologist and they can't help you, it's time to find a new gynecologist. So, very important to be able to measure these things. There's really no way to measure with pads or tampons because they're all so variable. Not all tampons are even that absorbent, so even if you expect a particular amount of blood to be absorbed, sometimes that doesn't even happen. So, highly encourage the use of those. And then for my patients who have severe cramping, once I pull them off of all of the horrible feminine hygiene products and they start utilizing the cups, they notice that not only does their flow slow down, but their cramps also decrease significantly. And that's because, again, physiologically, the permeability of that vaginal lining, if you are putting things in there that are very toxic to your system, your body is reacting negatively and it's trying to discharge it. So those crampy contractions are because it's trying to get it out and it's trying to tell you that there's a problem. So if you get those out of your life and you start utilizing the cups and the cramps slow down, then you will know that it's because your body was reacting to those toxic chemicals that were in those feminine hygiene products. So those are really good reasons to switch over to a cup. But again, try a few before you just toss it out the window. It's a little bit more difficult with people who travel. So I do travel a lot, and it's kind of frustrating on some days whenever you travel, but the more you utilize it, the more you get used to it, and you figure out how to get around different issues during travel. Alright, so on PCOS, because I just mentioned that earlier, polycystic ovarian syndrome, this little thing right here just says essential oils for PCOS. However, there's lots of other things that you can do, lots of different herbs. The company that I use for vitamins and herbs, the only company that I've used in practice in over a decade that I've been doing this, is Standard Process and MediHerb, and the reason why is because I have seen their facilities, I've seen their farm, I know how they do their chemical assays, I know what's in these supplements, I have access to all of that information, and I have seen how they work in patients. So these are the things that I utilize in practice. Those supplements are only available through doctors because you have to know what you're doing, and they don't want just random people taking random things and they really don't know what they're treating just because they read something online. So that's what I use in practice. It's really, really high quality herbs. Herbs and food products food supplements, you're going to get what you pay for. And if you go down to Walmart and you pay $2.99 for something or $6.99 for something, don't expect much, because that company is more so in it for profit margin. It probably costs them about 20 cents to make whatever they're selling you. So whenever you think about what you're putting into your body, just know in that realm, you do get what you pay for. That's why there's so many different articles about are supplements even beneficial, because if you're utilizing a supplement where the company is only concerned with profits, no, they're not going to be beneficial. So there's a lot of debate over how to use supplements properly, safely, and effectively, because not all companies are honest, straightforward, and really about improving the actual patient, more so about the pocketbook. It's unfortunate, but that's the world we live in. What you see over there, the little daisy, this helps to both plan and prevent pregnancy. So my daughter will never be on birth control because of the negative effects that it will give. So instead, I am going to teach her how to take care of her body and utilize something like the daisy, which can be a form of birth control. You can see their accuracy rate is 99.3%. And all you have to do is take your temperature. So again, it's working off of that BBT to help you determine when you are in your phase of your cycle where you are more likely to be releasing that secondary oocyte that can be fertilized. So that's the time you're going to want to stay away from sex if you're trying to prevent, or the time when you're definitely going to want to have sex if you are trying to conceive. Zinc I put on here specifically because zinc is responsible for about 300 different things inside of the body, but certainly incredibly important for hormonal balance. Again, this goes back to healthy eating. If people are not eating healthy and they are not getting the vitamins, the minerals, the cofactors, the enzymes, all of the things that are required in order to help make cellular metabolism work like it's supposed to, then you shouldn't expect for you to be able to do what you think you should do if you're not providing the very starting points in order to do that. So high zinc-rich foods include things like oyster and beef tenderloin, pumpkin seeds, which I absolutely love, and I love Brazil nuts. Not everybody can eat everything on this list though. Some people have a problem with dairy, so they shouldn't be eating yogurt, and some people have a problem with nuts, so therefore they should stay away from the nuts. So again, it has to be a personalized, individualized approach, and why you would want to work with someone who can help you so that you can have an easier way to figure things out of what is best for you. In regards to the sexual intercourse, whenever we're looking at the role of sex, this is an incredibly healthy thing that is done between two people who love each other. I understand that this act very often gets abused, and it is so unfortunate that so many people go through situations where they should never have been put in the first place. So that's not what I'm talking about. I'm talking about the willingness and the desire to have sex with someone whom you have committed your life to. So when we go through and talk about sexual intercourse, it is an incredibly healthy thing for your body because of how your autonomic nervous system will react. In males, you're going to have the arousal occurring because of an increase in your parasympathetic flow. So this is what's going to lead to erection. Parasympathetic, remember, is that rest and digest phase. Sex will help with balancing your nervous system between your parasympathetic and your sympathetic, because you're going to have to use both sides in order to have that pleasurable sexual experience. So the beginning part for males of arousal means that they are in parasympathetic mode, which leads to erection. During this time, this will initiate the secretion of those bulbourethral glands to help lubricate that glands of the penis, the head of the penis, which can then lead to emission and ejaculation. Emission is going to occur under sympathetic stimulation. So here we'll have peristaltic contractions of that ampulla of the ductus deferens that are going to push the fluid in the sperm into the prostatic urethra, and the contractions will help move that seminal fluid along the urethra. The sympathetic contractions of the bladder and the urethral sphincter will prevent the passage of semen into the bladder. Remember, they share sperm flow as well as urine flow, so those contractions will help ensure that the semen doesn't go in the wrong place, that it's going to come out into the external urethral orifice. Ejaculation is going to occur with powerful contractions in muscles that will help stiffen the penis and then ultimately push the semen toward that external urethral opening. This is what will cause the sensations that we all know and love called the orgasm. So it has to be sympathetic in that particular state for the orgasm to occur. So you got to start with the parasympathetic and then you end up with the sympathetic. After orgasm, then resolution phase will occur. This is when heart rate and blood pressure decrease. So sex is very good for the cardiovascular system. Blood begins to leave the erectile tissue, and then we go through the process of detumescence, which is losing the erection after the big O. So all of that is normal. If you have, however, a loss of erection before the big O, then that is called a deflating erection, and that's not normal. There are some causes behind this, include a number of different things. And interestingly, these very things are also the same factors that can cause a decreased libido in women. So if you look at these things, if a married couple is not experiencing pleasurable sex with one another, then there are some things that they may have to work through, whether that's anger issues or whether that's getting rid of certain alcoholic beverages, etc., in order to help with the actual process of sexual intercourse. Now, erectile dysfunction is also called impotence. This is the inability to either achieve or maintain an erection. This can either be physical factors or the psychological factors. Remember back to the triangle of health. You've got to have all three areas there in order to have true health. If erectile dysfunction is occurring, then got to be that detective and figure out why. What is it? Is this a mental emotional side? Is this a biochemical side? Is this a physical issue? For instance, if the blood flow cannot get into the penis because there is a clot somewhere, that is a physical issue that needs to be addressed. Now, in regards to female sexual function, again, we have to start with the parasympathetic activation. The parasympathetic activation, of course, is going to get the juices flowing and help increase secretion so that she feels lubricated and there is no dryness that would definitely cause pain. The blood vessels are going to fill with blood, so she's also going to become engorged as well. Clitoris can become larger, just as the penis becomes larger. And so this is incredibly important to understand that whenever you look at males and females, because they generally are driven by different things, sometimes in some females it takes longer to get over into the parasympathetic state. So guys should definitely know this, especially if you are married to someone who lives very high stress life. You're going to have to learn how to get them to get out of that sympathetic dominant driven state and get over into rest and relaxation. One of the best things to do for those females is massage, because massage is very relaxing. So, well, I guess as long as you're a good masseuse. If you're not, then I don't know, you may need to find some other things. But it generally will take a little bit more time for females to get over into the parasympathetic state, because if she is that female that's like laying there thinking, oh my gosh, I got to do this, I got to do that, I got to make sure that whenever I get up in the morning that this is done, she's going to have to learn how to come over into parasympathetic state, and sometimes it's up to the guys to help get her there. One of the things you can do, take stuff off of her plate. Don't make her think that she needs to do all those things by herself. You can get her over into parasympathetic a little bit easier in that way. And of course, the orgasm is going to be under the influence of the sympathetic nervous system. So this is why it's very important to allow her to reach her big O. Because if she does not, then basically you got her over into the parasympathetic state, and then you do your big O, and if you just leave her there and she's like, okay, well, what about me? You didn't balance my nervous system, you jerk. So maybe she doesn't say that, but you know, that's how you should view it, because you want to make sure that both of you experience the balancing effects of both parasympathetic and sympathetic. So those rhythmic contractions of those muscles, other pelvic floor muscles, are going to also help her experience that female orgasm that feels so great. Yes, there is a G-spot. No, you do not have to hit it every single time in order for her to have an orgasm. So there's different things that can be done, and it's always good to talk to each other. Be open, be, unashamed, because that's a time whenever you really get to be most vulnerable with each other and share an expression of love that should not be shared by anyone else in the entire world. It should be just between the two of you. Now, on this picture below, some females who have abnormal structures because of issues either in weaknesses of areas or because of, maybe kids mess things up a little bit. There's some other things that females have to consider that males don't. So in this particular picture, you can see the normal anatomy on a mid-sagittal section. You can see the vagina, you can see the uterus, but on the second picture, you can see what's called vaginal prolapse. Now, obviously, that's not a good day, right? Remember, the vagina has those muscles in it that you can strengthen. So what you're looking at in the third picture are what are called Benoit balls. You can see that there's different sizes of them, again, because every female kind of has a little bit different size, shape, structure. So if you put those inside of your vagina and you squeeze them in order to try to keep them from falling out, that is one way to help build your skeletal muscle without anybody even knowing about it. If you don't already do Kegels as a lady, then you should definitely be doing Kegels to help support your normal reproductive structures, okay? The Benoit balls can be found on different places like Amazon. If you've never heard of them before, don't be freaked out. You're going into healthcare. You got to learn about these things, and you got to know that things like this happen and how to prevent or how to avoid, or if they do, now, you know, this is going to be a surgical situation, and a surgical situation means there's going to be less sex because now there's going to be stitches and scar tissue, and it's probably going to hurt. So let's take care of it before it gets to that issue. In regards to contraception, there are so many methods to prevent pregnancy. So abstinence, barrier methods, IUDs, various different things that will help with preventing pregnancy, including the birth control. So whenever you're looking at birth control pills, there's a couple of different kinds. IUDs, there's a couple of different kinds. I'm not going to go through each and every single one, so I'm just basically going to let you know that whenever you use birth control, basically what you're doing is you're introducing a pathological process into your physiology. By introducing that pathology, what you're doing is you're telling your body, look, I know that it's supposed to work like this, but I don't want you to work like this. I don't want you to give me the ability to conceive, which is what is supposed to be normal for a female. So some will affect hormones on the brain, some will affect ovarian hormones, some will affect the ability to ovulate. There's all different ways that they do this in the different methods of birth control, but the reason why it can be damaging is because, remember, your endocrine system is a symphony. And if you start affecting one hormone, then you are going to affect multiple others. And I have had some patients who struggle with getting back into hormonal balance after they have been on contraception for years. And whenever they are ready to conceive, now they cannot conceive because their hormones have become so messed up. So it can be a scary situation. I do tell all of my patients, if you've been on contraception, don't even try to conceive for a year. Give your body a full year to just basically try to get things back to normal before you start the conception process, because you don't want there to be any issues along the way. I've seen it too many times, and it is nothing that I would ever wish upon anybody. So infertility is the inability to conceive or carry a pregnancy to term after 1 year of unprotected intercourse. After trying for 1 year, if you do not have the ability to conceive, you have not conceived, then we would say that you are infertile. This will affect about 10% of the population, occurs in males and females for different reasons. So there's a lot of different things that can occur that will cause the infertility, and again, this goes down to being a good detective and figuring out your patient. Unfortunately, the IVF procedures have become the only thing that people think is helpful for infertility, when in fact that's not. You don't have to shell out tens of thousands of dollars in order to conceive. There are things that can be done on a more natural route. I help my patients at much less of a cost than that. Amenorrhea is the absence of menstruation. So primary amenorrhea means the failure to initiate menstruation to begin with. This can happen in gymnasts because they are so high in androgens and they are lower in estrogen. So the signals just don't happen for the menstruation. Transient secondary amenorrhea means an interruption of your menstruation. This can be from several different factors. Again, you got to be a good detective. Have they gone through a very traumatic experience? Unfortunately, you do have to take all types of traumatic experiences into account, which is very sad. Are they losing an immense amount of weight because someone has called them fat? And now they are emotionally suffering, and that emotional distress is now causing a physical and a biochemical distress. So different causes of amenorrhea and lots of different things that we have to talk about and address in order to help those girls. STDs, also called STIs, obviously transferred during sexual intercourse. Lots of different types of diseases, and they can have lots of different pathogens, whether it's a bacteria, virus, etc. Make sure that these get addressed. Never should anybody walk around with what they suspect may be an STD and think that it's just going to go away. Got to get these things treated, because if you don't, it could lead to pelvic inflammatory disease, which is horrendous, very painful, and can lead to infertility. Aging, of course, is going to make changes in the female reproductive system as she goes through menopause, and then males, they have a comparable age-related change that's called andropause. However, this occurs pretty gradually over a longer period of time, so not all males suffer with andropause like a lot of women suffer for menopause. Andropause generally will happen between ages 50 and 60. This is whenever his testosterone decreases. Testosterone starts decreasing earlier than this, but this is whenever it really starts to affect him negatively. The FSH and the LH will increase as a way to try to get that testosterone to boost back up, which is why the pituitary gland will be sending out these hormones and trying to help get his testosterone back to a normal level. But again, if he's converting over into the estrogen because of the aromatase, then that's something that has to be addressed in order to help bring those testosterone levels back up. Sperm production will continue. As we've already said, it can continue up into his 70s, and then sexual activity will gradually decrease because of declining testosterone levels. Now that's different for all men. Some men, they don't decrease that activity and they keep going strong. So it really is a person-by-person basis. If a male really struggles with andropause and it comes on quite quick instead of a gradual process as normal, then that's whenever he may get that, what we call midlife crisis, and think that he needs to completely change his life and, get rid of his frumpy wife and get this hot 20-year-old with big boobs and a sports car, and that's really not the answer. So again, this is why you have to learn how to delicately approach men. Whenever they come in with a concern, think about what could happen in the future if you don't address that concern in a very respectable and kind way. So definitely don't want to go down the route of divorce and a sports car, because that really doesn't fix the underlying issue, right? Menopause, we've already talked about this a little bit, but basically whenever there are no more primordial ovarian follicles left, then we hit menopause. There's nothing left to grow up. Premature menopause is where those primordial follicles are gone before age 40. That's happening more and more nowadays because of the standard American diet, because of the massive amounts of chemicals that we are exposed to, and because of the toxins that we are constantly inundating ourselves with. The estrogen and progesterone will decline while the GnRH, FSH, and LH rises sharply. So again, the hormones from the brain are trying to come up because they're trying to stimulate those estrogen and progesterone to increase, but it's just not happening because there is nothing there, no primordial follicles to grow up anymore. Whenever you have a decreased level of estrogen in women, this can lead to reductions in the size of the uterus as well as the breast. Things will start to thin, not just the urethral and vaginal epithelia, other parts of her epithelia will thin as well. So her skin can thin in her face and in her arms and things of that nature. You will start to see changes all over the body as estrogen levels drop And there's also, of course, a reduction in the rate of bone deposition. Again, why exercise is so vitally important, because you can look at women who are 70 years old and in the gym every single day, and they look phenomenal. They look like they're 40, and that's because there is no pill, potion, lotion, cream, supplement, nothing that can replace the beneficial effects of exercise. There's so many good things that exercise can do for the body, so it is vitally important to let women know how beneficial it will be for them to get out there and do some exercise. It will help with all things. Normal human reproduction requires, of course, in males, we've already said, sperm count has to be adequate, semen has to be adequate, erection and ejaculation must function properly. I'm not sure where the Y went in that word. In females, of course, the ovarian and the uterine cycles have to be coordinated. You can't have a secondary oocyte that is released whenever the uterus is not ready to receive it. So there's nowhere for it to go if the uterus has not proliferated and gotten into the secretory phase. So those cycles have to coordinate. Ovulation and oocyte transport has to occur normally. They have to ovulate. If you're not ovulating, then you're not going to have the ability to fertilize that oocyte. And if that oocyte isn't making it into the tube, then you're not going to have the ability to fertilize. So those things have to occur normally. And then environment and reproductive tract must support the survival and the movement of the sperm, as well as the fertilization of the oocyte. Some women have such a harsh environment inside of their vagina that their husband's sperm cannot make it through. So I know that that sounds a little bit weird, but there is a procedure wherein doctors will bypass her vagina and put the sperm directly into the uterine cavity so that it can swim into the tube and get to the oocyte. And that's just because she has such a, I don't know what better word to use other than harsh, environment inside of her vagina that kills the sperm. So it is very important to make sure that everything is coordinated and working appropriately, because if not, then you cannot have fertilization, implantation, and a successful carry to term. There is a necessity for all things to be working, not just in the reproductive system, but also in digestive system, obviously endocrine system, that makes sense, nervous, cardiovascular, urinary, all of those are vitally important to the health of the mom. And if mom is not healthy, then it's going to be very difficult for her to have a healthy baby. So we've seen cases before where, a really unhealthy person who should not have gotten pregnant just miraculously ends up pregnant and is able to give birth to a very healthy baby, although they are very sick. So there are those cases where that will happen. But if you want to increase your chances of a successful pregnancy and a healthy baby, then you definitely want to make sure all of your systems are working appropriately. Even when everything is normal and fertilization occurs, again, a healthy infant will be produced only if that zygote develops into a full-term fetus. So what is a zygote? Well, in order to answer that question, we first have to look through these particular slides. As you can see here, you see the ovary. Look at number 1, you see ovulation. We know that the secondary oocyte is what is ovulated outside of the ovary under the influence of luteinizing hormone. Surrounding that secondary oocyte is that corona radiata. So if that secondary oocyte makes it into the fimbria and it gets into the tube and it meets up with the sperm and fertilization occurs, then great, we've got through step 1. But there's a whole lot more to go. Now what has to happen is a process that's called cleavage. Cleavage is basically cell divisions that occur over the first week of pregnancy. So what needs to occur is that female pronucleus the DNA genetic material inside of the secondary oocyte that has met up with the male pronucleus, the DNA genetic material that is within the head of the sperm. Whenever those two combine, that is going to give us our zygote. And the zygote is then going to go through these cleavage stages. So it's going to go from 1 cell to 2 to 4 to 8 to 16, ultimately to end up as what we call a blastocyst. That blastocyst is going to be divided up into a couple of different structures, but what you see there labeled as the inner cell mass is ultimately going to become the baby. So what has to happen is the blastocyst is going to have to implant into that endometrium, because we have a fluffy pillow, we have a good secretory blood vessels that are ready. Once it implants and it invades mom's uterus, it's going to tap into her blood supply. So this is a picture where you can see it's going into that endometrium, and as it burrows its way underneath that endometrial layer, what's going to happen is you're going to start to get HCG, which is a hormone that is going to tell mom's immune system, do not attack this baby. So if the HCG is not there, the immune system will sense that there is something wrong in the uterus, and it will go and it will attack, it will kill, and you will not have a successful pregnancy. So the HCG being released is the signal for the immune system to back off and to allow this process to occur. Of course, HCG is also the hormone that is going to be used by the pregnancy test to detect the fact that mom is indeed pregnant. But as you can see, this being burrowed inside of her endometrium, you're seeing some changes as it goes from that blastocyst stage in number 5 and moving into looking like different structures through 6, 7, 8. But 8 and 9 are where you can really see how things are starting to tap into her blood supply. Basically, it is invading those vessels so that it can get that blood flow as it is starting to set up what we refer to as the yolk sac before it has an umbilical cord and before it has a placenta. Now the thing about the placenta is the placenta will develop wherever the baby implants. So it's vitally important that the baby implants in the superior aspect of the uterus, because if the baby implants in the inferior aspect of the uterus, somewhere down near the cervix, the placenta can cover the cervix, which can lead to an emergency situation when that baby is born. If it breaks through the placenta, there will be internal bleeding, and it could put both mom and baby's life in jeopardy. So the goal is that all of the cleavage steps are going to be done in the tube, along the tube, so that by the time it gets to the blastocyst stage, it can implant in the superior portion of the uterus. That's why you want fertilization to occur out near the ampulla, to give enough space for cleavage processes to occur before it even gets into the uterine cavity. Of course, there's hormones that are going to be vital that they are working correctly in pregnancy. Not just HCG and progesterone and estrogen like we've talked about, but also prolactin, relaxin, and of course oxytocin. So there's so many things that have to occur in order for mom to successfully carry to term. It's amazing all of the different things that have to happen. The next time you see a baby being born, you just be wowed by how incredible it was that they were even born, much less with 10 fingers, 10 toes, and completely healthy.